is when the object is seen at the fovea of the eye, and if the motion is more than 5 degrees per second, then it leads to orthopsia. And we all know that the peripheral retinal image is always unclear. So there are three mechanisms which help in getting a clear image on the retina. First is the fixation. So the vision system always tries to detect a drift of the retinal image, and it programs corrective eye movements and suppresses the unwanted satellites. In addition, on head tilt and other such movements, we have got the vestibular ocular reflex which compensates for the eye movements. And the third thing is the neural integrator, that is the brain, which sustains an eccentric eye position against the elastic forces of the muscles and the ligaments. So the smooth visual fixation mechanism prevents the eye drifting away from a stationary object and relies on the microcellular portion of the visual system, and it's got a very fast response time. And so if there's a delay in the response time from this microcellular portion, then we might end up in having nystagmus. The visual cortex, the cerebellum and the pontine nuclei play a very important role in the maintenance or prevention of nystagmus. So signals from the visual cortex will be sent to the cerebellum via the pontine nuclei and the middle cerebellum peduncle. And the output cells of the cerebellum are the Purkinje cells, and any disintegration of this Purkinje cells will give rise to primary nystagmus. So because of these pontine nuclei and the cerebral nuclei, the convergence position of the eye is maintained as the eye moves together in different directions. The classification of eye movements is based on this particular classification, that is the CMAS classification, which was coined in the time 2001. That is the classification of eye movement abnormalities and strabismus. Broadly, if you look at this, it includes nystagmus and other ocular motor oscillations. It has got the physiological group, the pathological group, and it has also got other conditions like saccadic inclusions and oscillations and generalized problems. So the physiological fixation movements include the microtremors, the slow drifts, and the microsaccades, which assist the retinal and the visual function. The physiological nystagmus includes the vestibular nystagmus, in which the eyes will move away from the cold or the warm target. The optokinetic nystagmus, which can be illustrated by rotating a drum, and there is the rectilineation movement of the eyes, and the eccentric gaze nystagmus. And all these are believed to assist retinal or visual function. In the pathological nystagmus, we have got different types like the infantile nystagmus syndrome, the FMNS, and the SNS. So these are different kinds of nystagmus, and what we use, we go individually each type of nystagmus, and we just highlight the key points so that we have better understanding and easier recognition of these cases. So let's first look at the infantile nystagmus syndrome. Previously this was called as the old congenital and the motor and the sensory nystagmus. Now this happens in infants. It has got an accelerating slow phase. It is conjugate. It could be horizontal or torsional. It can be associated with albinism or achromatopsia. The important things are the ones which are outlined here. It dampens on convergence. It increases with fixation. There is a null zone. So let's look at this particular child. So this child has got a head posture. So when the child is turning the face to the right, you can see there is a lot of nystagmus. In straight gaze again there is nystagmus. But when the child turns the face towards the left, or there is a head up to the left, the nystagmus reduces. So there is a null zone which is present, and this child is having associated head posture. And it is also got a latent component. The fusion maldevelopment nystagmus syndrome, the FMNS, was the old latent or the manifest latent nystagmus. Again, the infantile onset nystagmus, usually conjugate, horizontal, and uniplanar. And if there is convergence, it can get blocked. The head posture is associated with the fixing eye in adduction. It decreases with increased fusion and decreases with age. So when we cover one eye, the nystagmus is more prominent in these cases. So this is the fusion maldevelopment nystagmus syndrome, and the key point here is that it is a latent kind of nystagmus which can be blocked on excited convergence. It will decrease when there is increased fusion, and it also decreases with age. This Mascus nucleus syndrome is very classic and typical because it happens in infants. It is associated with abnormal head posture and head oscillations. It can be disconjugate, can be asymmetric, and usually it disappears by 2 to 8 years of age. So here you can see in this particular child that child with high frequency nystagmus also got these head oscillations. The vestibular nystagmus would include peripheral vestibular imbalance, central vestibular imbalance, and central vestibular instability, or the periodic alternating nystagmus. Let's come to the first one, the peripheral vestibular imbalance. Now all these vestibular nystagmus will have vertigo, nausea, dizziness, oscillopsia, and all these problems. Usually they are of acute onset. The important thing about the peripheral vestibular imbalance is that it is suppressed by visual fixation. The central vestibular imbalance kind of the vestibular nystagmus is poorly suppressed by fixation of a visual target. And again, this is for the same kind of symptoms: vertigo, nausea, dizziness, oscillopsia, usually of acute onset, and the patient has an unsteady gait. The central vestibular instability, also previously known as the periodic alternating nystagmus, is again extremely typical. It is associated with periodic alternating head turns. This nystagmus is little affected by visual fixation. The head usually turns in the direction of the quick phase, and the eyes just move in the direction of the slow phase, and thus minimizing the nystagmus. And because of these head rotations, the nystagmus sometimes get dampened. So this is a periodic alternating nystagmus where there is periodic alternating head turns. The gaze holding deficiency nystagmus would include the eccentric gaze nystagmus, in which when the patient attempts to look eccentrically, the direction of the nystagmus will reverse, which is called the centripetal nystagmus, and after the eyes come to the center, the quick phase will come to the opposite direction, or a rebound nystagmus. So here the quick phase is always away from the center. But in the gaze instability nystagmus or the runaway nystagmus, the slow phase is away from the center. Now because of vision loss, again, there could be different kinds of nystagmus. It could be pre-chiasmal, chiasmal, or post-chiasmal. The pre-chiasmal, especially with bilateral vision loss, will end up in a jerk nystagmus. With monocular vision loss, it will end up in a pendular nystagmus in the blind eye. The chiasmal nystagmus is very typical. It is a seesaw nystagmus, usually by bitemporal field loss. And the post-chiasmal nystagmus is a low amplitude horizontal nystagmus beating to the side of the lesion. There will be other kinds of pendular nystagmus again, or nystagmus associated with diseases of central myelin. So we could have a demyelinating disease, or we could also have problems like internuclear ophthalmoplegia, like in this particular patient. There's absence of abduction in the left eye. Now, in other cases, the nystagmus could be associated with tremors of the palate, which is called as oculopalatal myoclonus. So this is associated with palatal tremors, and it could be associated with brainstem disease. In addition, we have other kinds which will be associated with Whipple's disease, in which there is GI events, oculomasticatory oscillations, and vertical gaze palsy. Ocular warping refers to rapid downward eye movements. It's usually because of pontine damage. Lid nystagmus can also be associated with vertical nystagmus. Upon the secondary inclusions and oscillations, we have got the square wave jerks, which are bilateral involuntary, small faster movements, which return very fast within 200 milliseconds, square wave jerks. If they return within 70 to 150 milliseconds, it is square wave pulses. We have also got the saccadic pulses, in which there is a drift away from the fixation point followed by a rapid drift back. We could have induced convergence interaction nystagmus as seen with various dorsal lesions, where there is light wave dissociation also. We could have the dissociated ocular associations, usually like the unilateral kind of movement which is seen in the abducting eye and internuclear ophthalmoplegia. And then hypermetric saccades are the ones which are the overshooting saccades. So we overshoot the target and then make corrective movement. We've got the macrosaccadic oscillations, in which there are back-to-back saccades which are happening all the time, which are trying to interrupt the fixation. We've got ocular flutter, which can again interrupt the fixation. But the only thing is that there is not a big intersaccadic interval. Superior oblique myoclonus is a very typical condition in which there is monocular blurring, and it is brought about by looking downward or by tilting the head towards the side of the affected eye, usually following trophlear palsy. So in summary, there are many types of nystagmus. The old motor sensory classification is possibly obsolete now. And there are very classic key differentiating features which we can use to classify the kinds of nystagmus. Thank you.